Diaphragm is a skeletal muscle that separates the thoracic cavity from the abdominal cavity and plays an important role in respiration. Understanding the anatomy of these structures allows us to better understand the unique clinical conditions that affect them. Let's start off by reviewing the innervation of visceral and somatic pain in the abdomen. The peritoneum is made up of two continuous layers, the visceral peritoneum and the parietal peritoneum. The inner visceral layer mainly covers the abdominal organs and has a visceral supply. Furthermore, both the visceral and somatic nerve supply of the peritoneum sense pain during different clinical conditions. However, the way in which they sense pain is different. The visceral peritoneum is innervated by the autonomic nervous system. When the visceral peritoneum is irritated, pain sensation is detected by visceral afferent fibers, which travel with the autonomic nerves, mainly sympathetic nerve fibers, back to the spinal cord. Visceral pain is typically sensed as a diffuse, dull pain, which is not very well localized, and the pain is often referred to the midline region of the dermatomal areas of the same spinal level as the autonomic nerve supply. Typically, pain sensed by the foregut visceral peritoneum is referred to the epigastric region. Midgut visceral pain is referred to the umbilical region, and hindgut visceral pain is referred to the hypogastric region. Patients who experience visceral pain may also present with nausea, vomiting, or sweating due to activation of the autonomic nervous system. On the other hand, the parietal peritoneum has a somatic nerve supply, which is the same as the adjacent abdominopelvic wall in which it lines. When the parietal peritoneum is irritated, pain sensation travels back with these somatic nerves to the spinal cord. Somatic pain is typically sensed as a sharp, localized pain specific to the spinal level innervating that irritated area. To illustrate these types of pain, let's use appendicitis as an example, where appendicitis refers to inflammation of the appendix and can cause both visceral and somatic pain. Visceral pain occurs due to irritation of the visceral peritoneum of the appendix and surrounding areas, which travel with sympathetic fibers back to the level of T10. As a result, there may be vague pain in the right lower quadrant where the appendix is, as well as anywhere along the T10 dermatome level, frequently being felt around the umbilicus. As the appendix becomes more and more inflamed, it can also irritate the parietal peritoneum, causing somatic pain, specifically a sharp localized pain to the right lower quadrant over the appendix to an area classically known as McBurney Point. Traveling from the umbilicus, the McBurney Point is situated at 2/3 of the distance between the umbilicus to the anterior superior iliac spine, and tenderness due to palpation over this area is a classic sign of appendicitis. In addition to appendicitis, there are many situations that can cause irritation and inflammation of the peritoneum, and this is called peritonitis. Often, peritonitis is the result of bacterial contamination, such as during open surgery, when the gut is penetrated during trauma, or as the result of a ruptured internal organ, such as the appendix. This exposes the peritoneum to gas and fecal matter, which is usually contained within the gastrointestinal tract, and allows bacteria to enter the otherwise sterile peritoneal cavity, leading to infection and subsequent inflammation of the peritoneum. Peritonitis causes intense pain in the abdomen and results in increased tone of the anterolateral abdominal muscles, which is a mechanism that aims to protect the contents of the abdominal cavity. Therefore, on examination, the abdomen is extremely tender to palpation, resulting in patient discomfort and voluntary guarding. Other signs include abdominal wall rigidity, which is due to involuntary increased muscle tone, as we just mentioned, as well as another clinical sign called rebound tenderness. Rebound tenderness is when you slowly perform deep palpation on the abdomen and then quickly remove your hand, which elicits a stabbing pain over the area of palpation, resulting in a rebound tenderness indicating peritonitis. Symptoms of peritonitis include severe abdominal pain, nausea, vomiting, fever, and constipation. Now, if the peritoneum is damaged or infected because of trauma, surgery, or peritonitis, fibrin starts to deposit on the inflamed peritoneal surface, which results in fibrous tissue formation during healing. This fibrous tissue, often referred to as scar tissue, can lead to the formation of adhesions, which are abnormal fibrous attachments between the visceral peritoneum of nearby organs or between the visceral peritoneum of an organ and the parietal peritoneum of the nearby abdominal wall. Abdominal adhesions are often the result of an abdominal operation, such as an appendectomy, and adhesion formation can limit the normal movements of abdominal viscera. Adhesions can cause chronic pain or complications, such as an intestinal obstruction, as the intestine can become tethered or twisted around an adhesion, and can also result in a potential volvulus. This is one reason why less invasive surgical techniques, such as laparoscopy, are preferred to open surgery when possible. Before we move on, we can't discuss the peritoneum without mentioning how one of its really cool features is that it can be used for peritoneal dialysis. The peritoneum is a semi-permeable membrane with a large surface area rich in blood and lymphatic capillary beds. The fact that the peritoneum is semi-permeable means that it allows certain substances or molecules to be rapidly absorbed, just like how the information in this osmosis video is absorbed into your brain. Okay, maybe it's not exactly the same, but you get the point. Now, in individuals with end-stage renal disease, waste products like urea accumulate in the individual's blood and tissues because they cannot be excreted, causing signs and symptoms like nausea, vomiting, pruritus, mental status changes, or even pulmonary edema. If the individual is unable to overcome the renal dysfunction, dialysis may be needed. There are two main types of dialysis: peritoneal dialysis, which takes advantage of the semi-permeable peritoneal membrane, and hemodialysis, where waste products are removed from the blood. Peritoneal dialysis involves inserting a large indwelling catheter in the peritoneal space, where a dilute sterile solution is introduced in the peritoneum through the catheter, which creates a concentration gradient between the blood and the fluid in the peritoneal cavity. This concentration gradient pulls waste and excess fluid from the blood and into the peritoneal cavity, where the fluid is then removed through the indwelling catheter. This procedure relies on the peritoneum's large surface area and semi-permeable membrane to eliminate waste. Quick quiz before we move on to the next section. What is the difference between visceral and somatic abdominal pain? Now let's talk about one of the unknown heroes of the peritoneal cavity, the greater omentum. The greater omentum is a large, four-layered peritoneal fold containing a large amount of fat that hangs from the greater curvature of the stomach. It is a very mobile structure which covers a large portion of the abdominal organs and, in doing so, prevents the visceral peritoneum from sticking to the parietal peritoneum. Furthermore, it has a protective mechanism where it can form adhesions and surround inflamed organs, such as the appendix, in order to wall them off and keep inflammation from spreading to other abdominal organs and viscera. The greater omentum is also a cushion for the abdominal organs against injury and also forms insulation against loss of body heat. Next up, there's the hepatoduodenal ligament, which is the thickened free edge of the lesser omentum that extends between the liver and the superior part of the duodenum. The hepatoduodenal ligament contains three very important structures: the hepatic artery, the portal vein, and the common bile duct. Due to the risk of hemorrhage during liver injury or hepatic surgery, the best way to prevent and control bleeding is to compress the hepatoduodenal ligament. This can be done using the Pringle maneuver, which is clamping the hepatoduodenal ligament manually or with the use of a clamp. During uncontrolled bleeding of the liver, the Pringle maneuver can be used to help localize the source of bleeding. If the bleeding stops, then the source is likely from the hepatic artery or portal vein, and if it does not stop, then bleeding is likely due to the inferior vena cava or hepatic veins. Alright, now let's switch gears and discuss the clinical conditions affecting the diaphragm. The diaphragm receives most of its sensory supply from the phrenic nerves, which carry signals to C3 through C5 spinal nerves, where the periphery of the diaphragm receives sensory innervation from the T5 through T11 intercostal nerves and the subcostal nerves. So, when there is irritation to the diaphragmatic peritoneum innervated by the phrenic nerve, this can result in referred pain to the dermatome area supplied by C3 through C5. This is because as the phrenic nerve is irritated, it sends this signal back to spinal level C3 through C5, and our body confuses this for sensation at the C3 through C5 dermatome levels. This would manifest as shoulder tip pain and is referred to as a Keurer sign. Can you recall another clinical condition that results in shoulder tip pain? That's right, a myocardial infarction can, because the phrenic nerve also innervates the pericardium. Going back to the diaphragm, irritation of the peripheral portions of the diaphragm will lead to more localized pain over the costal margin and anterolateral abdominal wall, as these areas receive sensation from the T5 through T12 spinal levels. Irritation of the diaphragm can be the result of numerous clinical conditions such as peritonitis, which we already talked about, or other things such as splenic rupture or a hemoperitoneum. Next up, let's talk about something called a pneumoperitoneum, which is when there is free air located in the peritoneal cavity. Free air is often recognized on clinical imaging, such as during X-ray or CT scan. One of the classic signs is on X-ray, where free air is seen underneath the diaphragm on an upright abdominal or chest radiograph, as seen here. A pneumoperitoneum is caused by any condition where air can leak into the peritoneal cavity. For example, any perforation along the gastrointestinal tract, such as a perforated ulcer or perforated diverticulum. Other causes include trauma, tumors, or even iatrogenic causes, such as injury during endoscopy. Remember our earlier talk about diaphragmatic irritation and shoulder tip pain? Well, free air under the diaphragm can also result in shoulder tip pain. Pneumoperitoneum is a sign of a life-threatening intra-abdominal condition and needs urgent surgical management. If you need a quick break, feel free to pause this video and see if you can recall what Keurer sign is. Moving on to something more annoying than dangerous, let's talk about hiccups. Hiccups are involuntary and spasmodic contractions of the diaphragm that cause sudden inhalations of air being pushed against the closed larynx, creating a variety of funny sounding noises from person to person. Hiccups are often the result of phrenic nerve irritation and can be caused by things such as gastroesophageal reflux disease, diaphragmatic irritation as we mentioned before, or any thoracic or abdominal lesion disturbing the phrenic nerve. Finally, let's talk about hernias. First, there are diaphragmatic hernias, which is when the abdominal viscera, for example the stomach or small intestine, can be forced into the thoracic cavity through any opening throughout the diaphragmatic surface. This can be due to congenital defects of the pleuroperitoneal membrane, or be the result of a blunt trauma to the abdomen, which causes a sudden increase in intra-abdominal or intrathoracic pressure, resulting in a defect of the diaphragm throughout its surface or at its attachment points. This increase in pressure leads to diaphragmatic rupture and herniation of contents through it. Now, diaphragmatic rupture occurs most often on the left hemidiaphragm, as the right hemidiaphragm is protected by the large mass of the liver. Second, there are hiatal hernias, which are a type of diaphragmatic hernia but occur when the upper part of the stomach pushes through the esophageal hiatus and extends up into the thoracic cavity. There are two types of hiatal hernias, a sliding hernia and a paraesophageal hernia. A sliding hernia is more common and is when the proximal stomach pushes into the thoracic cavity or slides into the thoracic cavity. This is due to laxity of the phrenoesophageal membrane, which is a membrane that circumferentially attaches the distal esophagus to the diaphragm at the gastroesophageal junction. Sliding hernias predispose individuals to reflux symptoms as gastric contents and acid can reflux proximally into the esophagus, leading to symptoms such as heartburn, indigestion, and epigastric or chest pain. The second type of hiatal hernia is a paraesophageal hernia, which is when the fundus of the stomach bulges into the thoracic cavity adjacent to the esophagus due to a hole or defect in the phrenoesophageal membrane. Large enough defects can even result in the additional herniation of the gastroesophageal junction, as well as other structures such as the spleen and bowel. Paraesophageal hernias are less common than hiatal hernias, but have a higher risk of complications such as gastric obstruction, ulcerations, and even respiratory symptoms. Alright, as a quick recap, the visceral peritoneum senses visceral pain, which is diffuse and non-localized and often results in referred pain, while the parietal peritoneum senses somatic pain, which is more sharp and well localized. During acute appendicitis, dull pain around the umbilicus is an example of visceral referred pain, where pain over the McBurney point is an example of somatic pain. Peritonitis is inflammation of the peritoneum, where individuals can present with intense pain in the abdomen, nausea, and vomiting, and clinical signs include a tender, rigid abdomen with potential rebound tenderness. When the peritoneum is damaged, the peritoneal surfaces can develop fibrous or scar tissue, leading to adhesions which can limit the movements of the abdominal viscera. A Pringle maneuver is when the hepatoduodenal ligament, which contains the hepatic artery, the portal vein, and the common bile duct, is compressed during hepatic surgery. The peritoneum can be used to remove toxic waste products in individuals with end-stage renal disease. This is called peritoneal dialysis and is a temporary solution for individuals needing dialysis. Any intra-abdominal or intrathoracic process which causes irritation of the phrenic nerve of the diaphragm can result in referred shoulder tip pain, referred to as Keir sign. Diaphragmatic irritation can also result in irritating hiccups. A pneumoperitoneum occurs when free air accumulates in the abdominal cavity and can be caused by things such as gastrointestinal tract perforation, trauma, or tumors, and is classically seen as free air under the diaphragm on X-ray. Diaphragmatic hernias can result from congenital defects or are acquired when an individual suffers blunt trauma to the abdomen, typically affecting the left side of the diaphragm. Finally, hiatal hernias are when the abdominal cavity contents herniate into the thoracic cavity through the esophageal hiatus. Sliding hiatal hernias are more common and occur when the proximal stomach pushes into the thoracic cavity due to a weakened phrenoesophageal membrane, where paraesophageal hernias are typically when the fundus of the stomach bulges into the thoracic cavity due to a hole or defect in the phrenoesophageal membrane.
The gastrointestinal tract runs from the mouth all the way to the anus and contains the esophagus that will give you a better understanding of the anatomy of the things in the lining of the stomach or duodenum that lead to inflammation in the gastric or duodenal wall. These are often associated with a specific stomach bacteria called H. pylori, Helicobacter pylori. Duodenal ulcers are more frequent than gastric ulcers and can be located anywhere along the duodenal wall, classically affecting either the anterior or posterior duodenal wall. If severe enough, ulcers can erode through the duodenal wall, which can cause perforation or gastrointestinal bleeding. Anterior wall duodenal ulcers are more prone to perforation into the anterior abdominal cavity, and this can result in a pneumoperitoneum because air from the gastrointestinal tract enters the abdominal cavity. A classic finding on X-ray is free air under the diaphragm indicating a pneumoperitoneum. This can also result in peritonitis because as duodenal contents leak into the abdominal cavity, they irritate the peritoneum. Posterior wall duodenal ulcers can also cause perforation, but more frequently they cause upper gastrointestinal bleeding. That's because the first part of the duodenum, called the duodenal bulb, is positioned directly anterior to the gastroduodenal artery, so an erosion of the posterior wall can also cause erosion into the gastroduodenal artery, resulting in an upper gastrointestinal bleed. Most gastric ulcers are located at the lesser curvature of the stomach, an area where both the left and right gastric artery can be found perfusing the stomach. So if a gastric ulcer erodes the lesser curvature, this can result in an upper gastrointestinal bleed. Gastric ulcers can also be located posteriorly, in which case they can erode through the stomach wall and into the pancreas. In doing so, these ulcers can also erode the splenic artery, which lies along the upper border of the pancreas, resulting in severe bleeding into the peritoneal cavity. Now, speaking of gastric blood supply, most of the stomach is well perfused with a rich anastomotic network. For example, the lesser curvature receiving blood from both the right and left gastric artery. The fundus of the stomach, however, is mainly perfused by the short gastric arteries, which are branches of the splenic artery. Unfortunately, these short gastric arteries have a poor anastomotic network, leaving the area they supply susceptible to ischemia following any blockage to the splenic artery. Therefore, any potential blockage to the splenic artery, such as atherosclerosis, emboli, or compression, can result in ischemia to the fundus of the stomach. To wrap up our discussion on stomach clinical correlates, let's talk about gastric cancer. The most common type of gastric cancer is gastric adenocarcinoma, which is capable of aggressive local spread and metastasis. The most common physical exam finding of metastasis in gastric cancer is an enlarged, palpable, sometimes even visible left supraclavicular node, also known as Virchow node. Metastasis may also spread to the periumbilical nodules, known as a Sister Mary Joseph nodule. Time for a quick quiz. Where are GI ulcers often located? What happens if a duodenal ulcer perforates posteriorly? Let's switch gears and talk about some clinical correlates regarding the small and large intestine. First, there's superior mesenteric artery syndrome, which is a rare cause of proximal intestinal obstruction, which is when the duodenum is compressed between the superior mesenteric artery and the aorta. Anatomically, the third portion of the duodenum passes between the aorta and the superior mesenteric artery as it courses from right to left across the abdomen. Typically, the duodenum crosses anteriorly to the aorta at the L3 vertebral level. The superior mesenteric artery arises from the anterior part of the aorta at the level of L1 and extends downwards into the mesentery as it goes on to supply the small and large intestines. In most individuals, the angle between the superior mesenteric artery and the aorta is at about 45 degrees, allowing space for the duodenum to pass between them. If this angle diminishes to less than 20 degrees, then the duodenum has the potential to become trapped between the superior mesenteric artery and the aorta, which causes compression of the duodenum, leading to superior mesenteric artery syndrome. Clinical presentation of superior mesenteric artery syndrome may present insidiously and are consistent with proximal small bowel obstruction. This narrowing of the aortomesenteric angle can occur with any condition that reduces mesenteric fat. This is often associated with things that cause large weight loss, such as malignancy, eating disorders, malabsorption syndromes, burns, or bariatric surgery. Furthermore, significant anatomic changes can lead to this syndrome, such as corrective scoliosis surgery. Symptoms of superior mesenteric artery syndrome can mimic those of bowel obstruction and include postprandial epigastric pain, early satiety, and in more severe cases, nausea, bilious emesis, and weight loss. Next, let's quickly go over some tips and tricks on how to identify the appendix during surgery. The appendix is normally located at the junction of the small and large intestine, roughly 2 centimeters below the ileocecal valve. To remove the appendix, the 3 Taenia coli are used as a landmark. The Taenia coli begin distally as a continuous layer of longitudinal muscle that surrounds the rectum below the serosa. At the rectosigmoid junction, this muscular layer forms three distinct longitudinal bands that can be seen on the external surface of the colon. These three bands continue proximally along the colon where they converge at the root of the vermiform appendix, so by following these Taeniae coli to the cecal base, the appendix can be identified. When in doubt, search for the Taeniae coli. Sticking with the appendix, recall that there is anatomical variation to the position of the appendix. The attachment of the appendix is constant to the base of the cecum, however, the tip of the appendix can migrate. The most common position is a retrocecal appendix, where the tip extends posterior to the cecum and extends superiorly toward the right colic flexure. Other times, the appendix lies beneath the peritoneal covering of the cecum, and in this case it's often fused to the cecum or to the posterior abdominal wall. The appendix may also project inferiorly into the pelvis. These variations can affect the clinical manifestations of appendicitis. For example, with retrocecal appendicitis, individuals may present with an iliopsoas sign, which is when pain appears during extension of the hip. A more anterior placed appendix may cause localized sharp pain in the right lower quadrant. Finally, when the appendix lies in the pelvis, atypical pain below the McBurney point may occur. Individuals can also present with a positive obturator sign, which is when there's pain on flexion and internal rotation of the hip as the appendix is in contact with the obturator internus muscle fascia and is stretched and irritated during this maneuver. Moving down our tubular pathway, let's look at a clinical condition affecting the vasculature of the large intestine. Remember that the GI tract is supplied by three major arteries: the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. Now, between these major arteries, there are anatomical areas called watershed regions, which are anatomical regions supplied by the terminal branches of two major arteries. In regards to the large intestine, its blood supply comes from the superior mesenteric artery and the inferior mesenteric artery. Therefore, any area that received blood supply from the terminal branches of both these vessels is considered a watershed region. One watershed region is the splenic flexure, or left colic flexure, which receives blood from narrow terminal branches of the superior mesenteric artery and the inferior mesenteric artery. Another watershed region is the rectosigmoid junction, which receives blood from narrow terminal branches of the inferior mesenteric artery and the superior rectal artery. Because they are supplied by narrow terminal branches, these two areas are more prone to ischemia due to hypoperfusion, which can be the result of blockage due to atherosclerosis, emboli, or thrombi. The main symptoms of colon ischemia includes mild to severe abdominal pain and cramping in the region where ischemia occurs, rectal bleeding, diarrhea, distension, and in severe cases, shock and dehydration. Next, let's tackle sigmoid volvulus, which is when the sigmoid colon twists around its mesentery, leading to obstruction of its lumen, compression of blood supply, and subsequent ischemia. The sigmoid colon has a higher likelihood of volvulus due to its freedom of movement, and the risk of volvulus increases with a particularly long sigmoid colon with a narrow mesenteric attachment. Symptoms of sigmoid volvulus have an insidious onset and include abdominal distension and progressive abdominal pain, and eventually signs of obstruction, such as nausea and vomiting. Now, on an X-ray, you can see a U-shaped distended sigmoid colon seen as a collection of gas, which can extend anywhere from the pelvis to the upper abdomen. If you look closely, this kind of looks like a coffee bean, which is why it's also called the coffee bean sign. Finally, let's wrap up this video by talking. Now, on an X-ray, you can see a U-shaped distended sigmoid colon seen as a collection of gas, which is a mesenteric attachment. Let's wrap up this video by talking about hemorrhoids, which is a term used to describe the dilation of veins in the rectal venous plexus. These vessels may become swollen or inflamed, leading to what we refer to as internal hemorrhoids or external hemorrhoids. Okay, now hemorrhoids result from the breakdown of the muscularis mucosa of the rectal wall, which allows rectal veins to prolapse through. Hemorrhoids are classified into internal and external hemorrhoids based on their location to the pectinate or dentate line. Internal hemorrhoids are located above the pectinate line and affect the internal venous plexus, which drains into the superior rectal veins. External hemorrhoids, on the other hand, are below the pectinate line and affect the external venous plexus, which drains into the inferior rectal veins. Due to their position above the pectinate line, internal hemorrhoids receive visceral innervation from the inferior hypogastric plexus and are not sensitive to pain, touch, or temperature. External hemorrhoids, however, receive somatic innervation from the inferior rectal nerve, a branch of the pudendal nerve, and are therefore sensitive to touch, temperature, and pain. Both types of hemorrhoids are typically asymptomatic. Internal hemorrhoids can prolapse through the anal canal and become compressed, which may cause strangulation. Alternatively, internal hemorrhoids may bleed, resulting in painless, visible bleeding coming from the rectum. External hemorrhoids can become inflamed, causing itching and discomfort, and due to the somatic innervation of external hemorrhoids, they can be a literal pain in the behind if they thrombose. Hemorrhoids are often the result of increased intra-abdominal pressure, and can result from chronic constipation, pregnancy, obesity, and increased straining on defecation. Alright, as a quick recap, When duodenal or gastric ulcers perforate the anterior wall, that can cause a pneumoperitoneum, which is associated with free air under the diaphragm on an X-ray. Posterior wall erosion of duodenal and gastric ulcers, as well as lesser curvature ulcers of the stomach, can cause gastrointestinal bleeding. The fundus of the stomach is supplied by the short gastric arteries, which are prone to ischemia if there is a blockage to the splenic artery. Next, signs of metastatic gastric cancer would be a left supraclavicular node enlargement, known as Virchow node, and periumbilical nodal enlargement, known as Sister Mary Joseph nodule. Superior mesenteric artery syndrome is a rare cause of proximal intestinal obstruction where the third portion of the duodenum is compressed between the aorta and superior mesenteric artery. During an appendectomy, the Taenia coli can be used as a landmark to find the appendix. The position of the appendix can vary. It can lie behind the cecum, beneath the peritoneal covering of the cecum, in which case it's often fused to the cecum or abdominal wall, or it can project inferiorly into the pelvis. The watershed regions of the colon include the splenic flexure and the rectosigmoid junction, and these regions are more prone to ischemia, due to the fact that their blood supply is provided by narrow terminal branches of the superior mesenteric artery and inferior mesenteric artery. Sigmoid volvulus happens when the sigmoid colon twists around its mesentery, causing obstruction in the descending colon, and it can cause the coffee bean sign on an X-ray. Finally, hemorrhoidal disease is when the internal and external venous plexuses of the anal canal become swollen. These include internal hemorrhoids, which are found above the pectinate line, and external hemorrhoids, which are found below the pectinate line. Both are often asymptomatic, however, external hemorrhoids may cause severe pain if thrombosed.